Okay. Yes?
What is the maximum amount of levodopa that you would ever prescribe?
Okay, and that's, actually that's a more complicated question, okay, just so you know, because that would depend upon where in the course of the disease you are. Because as you can imagine, if it's the first time you've ever seen it, there's only, you're going to be more sensitive to the medication. But if you've been on the medication for 10 years, you can tolerate a whole lot, okay? But generally, in terms of the rule of thumb, in terms of the first time I ever see a patient, I will go up to 2,000 milligrams a day, okay? And so I would do that. That's what I would need to do to establish whether you're not responsive, okay? Typically, the patient, well before I get there, they will have a response at a much lower dose. The typical patient will have a response. And so the only patients that I really push up to the high are the patients that I'm trying to prove to everybody that the patient doesn't respond to medications at all. And so those are the ones I push. Secondarily, the people 10 years later after they've been on levodopa, yes, if that was the only medication they're on, they could be up to that dose anyway after 10 years because they metabolize it so fast, they could take the medication every 2 hours or something. Of course, it could be up to that high of a dose, okay?
For just patients in general, with them being on the medication and everything, how often should they have a doctor's visit?
Well, it depends on what's going on. And so if they're doing great, I may have patients not see me for 6 months because they're doing great, because they feel normal, okay? And so even a year, especially the early patients, the tremor dominant, they're doing wonderful and the progression is slow. There's no reason why I need to see them that often. On the other hand, if the person is doing really bad, they can't do anything, they can't take care of themselves, they're having a lot of side effects, everything is going wrong, they're passing out and falling, they can't throw up, they're throwing up on their medications, all that. Of course, those patients, I may see them, once a week or something until I get them figured out, okay? I'm willing to do that, it depends on the case, it depends on the situation, what's going on. Do I need to intensively figure it out or have them stabilize so that I can wait a while before I see them again? Okay. Yes?
I think probably the most emphasis should be on the managing of these patients.
Mm-hmm.
Because it is my experience with the patients that we see in our office, and we don't treat them from the medical
Mm-hmm.
standpoint. However, we get a lot of feedback from the neurologists,
Mm-hmm.
and I'm seeing in a year,
Mm-hmm.
and I've been put on this dosage of medication,
Mm-hmm.
and it's making me sick, but I'm not supposed to go back for a year.
Oh yeah,
Crazy.
and that is crazy because what I would do is I would have them come back before then to figure that out and make adjustments so they're not feeling sick anymore.
Exactly.
And so it's a matter of just listening to the patient.
Exactly.
That's all
If
it
you
is.
don't find a doctor like Dr. Saw, then you've got to press your doctor because it's not right to be on medication that's making you ill
Yeah.
or sicker
Yeah,
or something wrong.
exactly. Yeah, I've seen that a lot, actually, unfortunately. Yeah.
It's unfortunate.
Okay.
Yes.
Okay. Was there another question over here? I thought someone.
No, you answered the question
Okay.
with your conversation afterwards.
Okay. So anyway, I say so we look for the hallmark features. You don't have to have all three of them, but you want to have two of them at least, okay? And then one of the two has to be bradykinesia, and the other one could be either rigidity or the rest tremor, okay? One or the other, okay? So you have to have two, okay? And then you have to exclude every other cause. There can't be any drugs that would do it. There are a lot of drugs that can do these symptoms, so you got to exclude that. There can't be other things like a stroke or hydrocephalus or tumor or anything else like that that can explain it. Okay, you have to rule those out. And then the other thing, in terms of the history, does it progress slowly? Because that's how Parkinson's progresses. It progresses slowly. It doesn't happen just like that. That would be like a stroke. That's why it's called a stroke, right? You have it right there, and then the symptoms happen. So in Parkinson's, it progresses slowly. The other thing is that typically, but it doesn't always have to be, typically it starts on one side and then it spreads to the other side. So it's kind of uneven. Those are all typical things that we use to kind of support the diagnosis. And then, of course, is the response to levodopa and what happens over that. So in other words, when a neurologist makes a diagnosis, you myself, we may not know the first time we saw you. We have a strong suspicion. We may need a few visits before we know for sure, okay? Because we have to see how things progress over time, okay? Okay. Okay. All right. So this is just to show you that there is published data that shows that doing this criteria works, okay? Now, back in the 90s, when we weren't using the criteria so much, our accuracy wasn't so good. It was more like 75%, 76%. And then by the early 2000s, we got up to 90%. And then in the specialty movement disorders clinic, like myself, our accuracy can be as high as 98.6%. And so if you think about that, that's really accurate. Even if we had a test, because no tests are perfect either, because even some tests can be wrong. They can have, this kind of even matches or beats some of those tests. So this just shows that if you go see a specialist and they take the time to go through the criteria very carefully and eliminate all the possibilities, the likelihood of them being correct is very high. Of course, it won't be 100%, but it's going to become very close to that, okay? And so over time, after more visits, the accuracy will increase as you get more information together, okay? Okay, yes?
Can a previous stroke, 5 years later, cause you to have a tremor and a shuffling gait that you didn't have in the interim?
No, not really. If you had, but stroke is going to cause anything. It's going to cause something at the time that it happens. It's not going to happen later, okay? Because what a stroke does, it causes something, and then your brain tries to heal up, and so whatever it caused, it slowly starts to go away over time, okay? So that's very different from Parkinson's. Instead of it slowly going away and getting better, it's going to slowly keep on getting worse, and so you could tell by the progression that one is very different from the other. Okay? Okay. And so this is just to, when I'm going through some of the other causes, I mentioned the medications, the toxins, the strokes, the vascular ischemic causes, the tumors, and also the infectious causes they're there. Including, I'm sure that some of you all must have seen the movie Awakening, when they were, with Robert De Niro, and they're showing all those people who had post-encephalitic Parkinsonism. And they surprisingly responded well to medications like Evidova as well. But obviously in their case, they had the illness, and then they had the Parkinson's after the illness. And so, things like that can occur, but they are kind of rare, but in terms of causing it. But just so you know, those are possibilities as well, okay? Again, these are the Parkinsonian syndromes. They're, just to let you know, if you have Parkinson's, yes, it can affect your memory, okay? However, if you have Parkinson's at the beginning, you should not be demented though, okay? Do you know the difference between being demented and just having a memory problem? Yes. You do? Okay. Okay, can you elaborate?
Dementia is a larger process of the brain being spindled up.
Okay, and so in a practical sense, how would you explain that to everyone else here? Yeah. What is larger?
Yeah, larger bundles of nerves that are bundled together in the brain.
Well, yeah, but there's more parts of the brain affected, but from us in the practical sense, the way that the psychologists make the decision is, once the memory problems get bad enough so you can't take care of your daily activities, that's when it's dementia. If you have memory problems but you could get by, then it's not dementia yet, okay? So anyway, what I'm saying is that if you have Parkinson's, at the time of diagnosis, you might have memory problems, but it shouldn't be dementia, okay? If you have dementia, you have to think about some of these other things. There's something called dementia with Lewy bodies. And so this is another disease that has Lewy bodies. So even though I told you in the earlier picture that Lewy bodies is characteristic of Parkinson's, there are other diseases that have Lewy bodies too, okay? And so dementia with Lewy bodies is one of those. They have Lewy bodies everywhere. They have Lewy bodies in the brain, and they're scattered all over the place. And those persons have dementia early on, okay? The other thing to keep in mind too is that Alzheimer's can also have Parkinsonism too. So you can have a person who has Alzheimer's and had the diagnosis, and then later on they get Parkinsonian symptoms, right? They don't have Parkinson's and all of a sudden they turn into, they don't have Alzheimer's and all of a sudden turn into Parkinson's. No, they have Alzheimer's and they got Parkinsonian features also, but they still have Alzheimer's, okay? So I know, and I've had many patients, including some close friends of mine, where the doctors got so confused about the terminology. My friend was telling me, oh, my mother had Alzheimer's, but now they think they have Parkinson's now. And so I'm going like, that doesn't make a lot of sense. You know, Parkinson doesn't do that. You have your Parkinson's symptoms, and then after you've had it for a while, you could get dementia later on, okay? So it shouldn't be there at the beginning, okay? Okay, and so other things like that too is like, you have multiple system atrophy. Pathology-wise, it looks different. After you have the brain and you look under a microscope, it doesn't have Lewy bodies, it has something different, okay? But before that, they have a lot of problems with regulating the blood pressure, regulating bladder control, all kinds of problems like that. Yes, in Parkinson's, after you've had it some 10 years or so, you might get some of those symptoms too. But in MSA, you can have those symptoms very early on. And so that's how you could distinguish it. The other thing I want to say is that nobody wants to have these other syndromes. Parkinson's disease is by far and away preferable to having any one of these, okay? Okay, Parkinson's disease, there are things we can do for it, okay? Really, medications can make you normal for a while. It may not make you normal forever, but you know, it can make you normal for at least a little while, okay? With these, unfortunately, nothing's gonna work, okay? The medications don't work. If anything, the medications make them worse, okay? So a lot of times you're just doing supportive care. And so these sort of things will shorten your life. In Parkinson's, in contrast, if you take care of a person really well, make sure they're on the right dose of medications, and do therapy and exercise and everything like that, you can live as long as anybody without Parkinson's. You can. It can be done, okay? And so just keep that in mind, okay? Okay, and these are some of the things that if we see that we make us a little worried. It doesn't guarantee there's something else, but it makes us worried about some other process going on. If there's things like this in the history, then I would do more things with like getting an MRI and things like that. I gotta tell you that I do not routinely get an MRI in every Parkinsonian patient. I get an MRI on a patient with Parkinson's that has something odd that makes me worried, and then I'll do the MRI to look for other things. There's no way to make a diagnosis using an MRI. Absolutely, MRI doesn't do it, okay? Okay. And the other thing, I know that there's another scan, we'll talk about it a little bit, but the limitation on the other study too. And so all these things are little signs that a movement disorder neurologist will use as an indication for maybe being concerned about something else going on, okay? Okay.
Dr. Song?
Yes?
What do you consider early dementia? How is that you got
Okay.
early before many of those
Okay.
symptoms are there?
What I say is that what I'm saying is that in the typical Parkinson's patient, they will not get dementia until about 15 years after the Parkinson's was first diagnosed. That is typical. Okay. So early dementia means dementia within the first 3 years of their diagnosis. That would be a red flag about maybe something else is going on. Okay. Okay.
Thank you.
Yes?
Will somebody with Lewy body disease respond in terms of the dementia to the levodopa? Can it improve the dementia?
No, actually, the levodopa is only helpful for movements only. It doesn't help with the thinking part, okay? So actually, in dementia with Lewy bodies, we use the same medications as we do with Alzheimer's. We use acetylcholinesterase inhibitors, and they actually respond quite well to those medications, you know, like Aricept, Exelon, those kind of medications. They can do very well with that. Okay, and just so you know, and I'll introduce this a little more in a later, is that in Parkinson's, dopaminergic neurons are not the only neurons affected. The acetylcholine neurons are also affected, and that's part of the reason why the memory gets affected eventually. So keep that in mind. Even though we focus on one very small little area and think about dopamine only, the truth is that Parkinson's is far more than that, okay? All right, so anyway, what I was getting here is that I don't do imaging with the classical patient because if you have all the other classical features that supports the story, I'm pretty confident about the diagnosis, and I will be very comfortable about nothing else happening, okay? And so I just save the other tests when I'm not sure. Occasionally, of course, there'll be patients that you're not sure about, okay? One final comment about the DAT scan. I know that it's been approved, and of course, it can only prove Parkinsonism, okay? It doesn't prove which type of Parkinsonism. It can't tell MSA from Parkinson's disease from PSP. It can't tell them apart, okay? So in other words, if you have a tremor that's kind of unusual, that it looks like an essential tremor, Parkinson's tremor, and all kinds of tremor, and you can say, wow, this is a confusing tremor, I don't know what it is. Yeah, then you can get the DAT scan that could help us sort it out, okay? But with the Parkinsonian patients, it really isn't going to add more information than what I already said. You can already tell the guy is a person is Parkinsonian. The issue is you got to figure out which one it is, okay? And that can only be done by some of the things that I've already mentioned with the medication and the history. It's not going to be done by the scan, okay? Okay, and then these are just the classic Hoehn-Yahr staging. You're all probably very familiar with this, stage 1, 2, 1 all the way to 5, okay? When it's only on one side of the body, it's stage 1. Both sides of the body, it's stage 2. It affects your balance, it's stage 3. When you start getting disability, stage 4. And when you're completely dependent, it goes up to stage 5, okay?
And if somebody really wants to see how that looks, you can go on our website, and we've got information back there that'll give you the website, and go into the search bar and search for stages of Parkinson's, and we'll not only get the text version of what Dr. Song is telling you, but you'll also get the visual version of it.
Okay, and the other thing to realize is that not everybody goes through all stages, okay? Just so you realize, you can skip 1 and start at stage 2, okay? Just so you know. And so some people go to stage 4 and never go to 5, just so you know. It doesn't mean that you're going to necessarily have to go through every single one of them. But that's just a typical progression slowly over time, okay?